warahmatullahi wabarakatuh. Good evening, everyone. Welcome to our meetings, which will be about a trend and update in Afib management. We have two guest speaker, the Dr. Abdullah Shahab, and I'm sure everyone knows Dr. Abdullah Shahab. He's a professor and consultant in cardiovascular disease, and he is the chief editor of a New England medical journals in UA branch. And he will be the first speaker. He will be talking about the improving patient outcomes and through atrial fibrillation screening, current situation and future directions. And the second speaker will be Dr. Mu'taz Qadri. He's well known also. He's a consultant cardiovascular disease and consultant electrophysiologist in Sheikh Khalifa Medical Center. And he will be talking about how is real world evidence helping to inform care for patient with atrial fibrillation. I would like to, before we start, just to please, if you see the icon below the screen, there are question and answer icon. If you would like to ask question, please put your question through this icon, and we'll try by the end of each session openly for a question. Unless if we found that time is tight between the two talk, then we'll do it at the end. So I would like to welcome Dr. Abdullah Shahab to start his first talk. Please, Dr. Abdullah.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you very much, Dr. Salim Al-Ka'bi. I'm sure all of you guys knows Dr. Salim Al-Ka'bi. He was the head of the working group of electrophysiology in UAE and also the Gulf, and very active. Great to have him with us and moderating our sessions. I'd like to thank Emirate Cardiac Society for a series of events we do with our experts and working group, and great to have Dr. Mu'taz with us as well. So it's really my few minutes talk on screening for atrial fibrillation and how that can help us to maybe able to intervene sooner. I will go through some studies done in the past, but not go in deep, just highlight them. Then discuss what is clinical atrial fibrillation, what is subclinical, and the difference between them, and then show what are the screening tools we have to detect atrial fibrillation. Then end up maybe with some more questions than answers. Okay, so this is the problem. Is prevalence of atrial fibrillation increasing because we are getting older, and that's varies from country to country, but it's really in average it's around 2%, but it goes up to 10%, and responsible for a third of the strokes, as all of you know. Asymptomatics in up to 80%. That's why it's important to screen for them. Early identification of atrial fibrillation, I think, is important since we have new therapeutics available, and I think Dr. Mu'taz is going to discuss that in more details with you. So this is what we'd like to prevent, and the problem, when this happens up to 10% and atrial fibrillation detected in the stroke. So really, this 10%, how can we detect them as before the stroke? And it was possible to detect those who have asymptomatic atrial fibrillation earlier. It may be possible to prevent some of these strokes by offering, the newest oral anticoagulation we have nowadays. So when it comes to the screening, I think this is applied to everything. It's from WHO. Should be an important health problem. I think we all agree atrial fibrillation is important arrhythmia. It's one of the commonest or the commonest chronic arrhythmia, and it's available treatment. Yes, available. We had Warfarin, we have NOACs now. Facilities to diagnose this, yes, we have many ways, and I'm going to share with you some of these. Asymptomatic phase, yeah, there are asymptomatic phase, and we have two experts here, because Salim and Mu'taz can tell you how we can detect that. The test is acceptable and sensitive. I'm going to share with you the sensitivity and specificity of these tools we have. Natural history of atrial fibrillation, again, we are learning. We don't say we know everything. We are learning, and you can see it's compared to 10 years, a decade ago now, we have more idea and how to manage that. Screening should be a continuous process, of course. It's nothing just one episode. Should be like anything else, evaluating the patient. Cost of case finding will balance with the overall cost. Of course, you don't want to do a test which is very expensive and yield will be low. This is, of course, if you have a test, ECG like this to do is, of course, very difficult, and you cannot apply to everyone. And of course, the yield will be very low. So we had in 2017 some ideas: who to screen, where to screen, how to screen. It says, the age is important, and who are people with atrial fibrillation who are undertreated. These are the people we need to screen. Possible those who are less than that. Primary care, we might need to focus on for our place of screening. Advisable places like non-medical, which we did in shopping and mall and various venues. How to screen? There are opportunistic way to do it. Single time we can do. Other device I'm going to share with you. So age is important. You don't, young people, the yield will be low. 65, 75, even much better. 85. As we get older, the more opportunity, and it varies between female and male, more male than female. And it tells you, what device we use. Opportunistic screening, like ECG, pulse palpation, or intermittent prolonged one, systematic screening, or more intensive one, which, it costs a lot of money, but again, you're going to yield more. And that based on evidence and come from the guidelines. These are the devices we have, and I'm sure, more, in UAE we have all of these available, and in the right places with the right experts, you have. You can provide you with the one which is, more appropriate. And this is in a different way looking at it. And that was like here you can see the real one, and how to do it. And you have a regular pulse detection, single leads. You have an implanted one. And sensitivity and specificity of this. So pulse pulsation is sensitivity 92, 82 specificity, and you have smartphone. Again, you see, really the sensitivity is very good. A smartphone ECG, that varies, depends on what type of the manufacturer. Smart watch, and you've seen that. So ECG confirmation not needed here. Here we need it, and you see that's in the study we've done with the Apple study. So this is the latest. This is the latest from the guidelines. So you can see how important, when screening for atrial fibrillation, it's recommended that the individual, so the one we are going to discuss with, to know about the significant and treatment of implication of detecting AF. There's no point just detecting AF, and that's it, because it's lots of consequence of that. And having atrial fibrillation means multi-specialties approach to this management. It's not only electrophysiologists or cardiologists, GP, nurses, many people will be involved in the management. And the consequence of that, the adverse of that, either from medication, from psychological aspect point of view, from adverse effects of that. So lots of things come with it. So that's important to have that dialogue started before you start screening. Structured referral platform is organized for screening positive cases for further physician-led clinician education to confirm the diagnosis AF and provide optimal management patient with confirmed AF. And definite diagnosis of AF and screen positive cases is established only after physician review single lead ECG recording more than, so that's called clinical atrial fibrillation. Less than that is subclinical. So clinical, you need more than 30 seconds or 12 lead ECG to confirm that shows atrial fibrillation. So the risk of the, again, screening, like anything else, this because of anxiety, you tell somebody you have atrial fibrillation, then you remember I'm going to have a stroke, I'm going to have heart failure, and then the problem which comes with that, of course. So these are all the risks, and the benefits, of course, is we will know. If you detect these as early as possible, you're able to prevent the stroke and the consequences of that. So this is just a quick to know what's the difference between the subclinical and clinical, and things like something like I'm going to show you what was that. What was it? this one, AHRE, this is another is a small part of the subclinical atrial fibrillation. Of course, these are only detected on, devices like, implantable devices, not clinically, you can see that. So these are all something, we need to do, use all the different type of screening to able to detect this. But again, what's the consequence? What happens if we detect that? Are we going to intervene? And if we're going to intervene, how much benefit we get from that? We still don't know. We are learning. So it tells you here, those who are low risk CHADs and start rare, that's what I mentioned, atrial high risk events or subclinical atrial fibrillation, low daily burden. This one, and as we get higher, so that if you have more than 24 hours, that means you are coming to have a risk now. If you have more CHADs, you have a risk. So you need more burden and more CHADs to have a high risk of having a stroke. So these are important when you come to management. And this is the way to detect the subclinical atrial fibrillation. And it's a variant type of atrial fibrillation, but differ in, so would not be detected by means other than the implanted device with continuous 24/7. So it really is not that easy to detect this. You need intensive way to detect this subclinical atrial fibrillation. And here's the importance of that. So patients who are got more than 24 hours, which so these patients look at the events, it's high. But those who below 24 hours of having atrial fibrillation, their risk is much lower. And then intervention should be based on not only just detecting atrial fibrillation, based on the age, based on the overall CHAD VASC. Stroke risk for SCAF is lower than the overt AF. In orange, you can see, those who are in clinical atrial fibrillation, they have high, depends, their CHAD VASC 2 or 3 compared to who are subclinical or atrial fibrillation or not even subclinical atrial fibrillation. So the risk is really remain below 1%. So this tells you how important is to know what are we detecting, clinical, subclinical, or just high event of atrial activity. So this is the problem with atrial fibrillation. Detecting atrial fibrillation is really, as you can see here, is patients should optimize risk, stroke prevention, symptom control. You go to the many things after that. And that means lots of lifestyle evaluation and targeting. And it's multi specialties. It's not one person job. Everyone is involved in this. That's why it's the burden of really, when you're able to detect this and prevent it, you're able to save a lot of money from a stroke consequence, which costs a lot of money to the government. So in summary of what the guidelines says, opportunistic screening for atrial fibrillation by pulse taking or ECG rhythm strip is recommended in patients above 65 of year age. So that's class 1. That means all the X-ray, me, Dr. Salim, and Mu'taz, we all agree to that. So that's consensus. It is recommended to integrate pacemaker and implantable cardioverter defibrillator on a regular. So this is something, what Dr. Mu'taz and Dr. Salim will tell you. So how we can detect AHRE, which is atrial high rate event. So how to detect that is through only from using implantable cardioverter. But finding this is depends on the burden of it and also the CHAD VASC. When screening for AF, it is recommended that individual undergo screening are informed about the significant and treatment implication of detecting AF. Very important. This is the most important thing because nothing going to work if you don't do that kind of share decision. Structure referral, we already mentioned that definitive diagnosis is important and systematic ECG screening is important. So just quickly, I'll go through the study being done because really each of these studies requires a lecture itself. I mean, this was the first, I think, 2 years ago, 2019, Apple Heart Study. big, look at how many numbers of people involved in this individual. It's like a massive, you're approaching high scale, large scale assessment of using smartwatch, sorry. So those who are above 65, 24,000 out of 419. If you look how many people, this is the way they used it. I don't go detail methodology of it, but really what tells here is the positive predictive value of detecting of atrial fibrillation is quite great. It's 0.8, at 84%. And positive predictive value for simultaneous AF on ECG with subsequent irregular is about 71, which is good really for something like that. So we're detecting 0.4%, which is, you are focusing on a huge number who are, you don't know, everyone's involved in this, and you can detect these people and help them in future. And so another way is a study called a Stroke Stop, example of community screening program. Here, just those who are at risk of atrial fibrillation, this age starting, so above 75, those who were detected to have previously unknown AF is about 3%, quite good number. And those who are atrial fibrillation without NOACs, 2.1. So you actually done by one test, you managed to find those who are not detected and find people who are not on treatment. So great way of, and this is accumulated, so you need to do this many times to get more numbers on board. And it helps you to detect patients who are, of course, it depends what you're going to use, handheld ECG or 12-lead ECG. So you yield more, of course. And this helps you to prevent, to stroke, according to the study, of course, this one, before intervention, after intervention. You can see, compared to the control, quite significant between this and this. You can see much better than on the control way. We can use also the NT-proBNP to help us to find out who are at high risk of having atrial fibrillation, so we can focus on them, whether using things available, easy way of detecting screening, or go for the 2-week intermittent ECG, and that yield about 4.4% of patients having atrial fibrillation in this 14,000 individual. What about future? I think artificial intelligence. By looking at their ECG, which is patients who look at their ECG looks all like sinus rhythm, but from putting lots of data and experts, their background and risk factors, many things together, this machine able to tell that which one of these is going to have atrial fibrillation in future. And really it's been as accurate as 87% or 90%. So that's really, I think, a future. And that was the American study. This was a Chinese study as well, and it tells you the same information. So this study, it just tells you it's not really what is important. It's not the device. It's not the device. It's not the setting. It's not the geographical region. What's important here is this one. It's the age is important, and the CHA2DS2-VASc. And those who are above 65, where you can detect more atrial fibrillation. Here you can, if you intervene, you get the most benefit. Looking at all type of opportunistic and systematic screen method, looking for atrial fibrillation, whether that's single ECG or those with proper follow-up and implanted device with high intensity, where you get more yield, but of course, and more intensity. But the trade-off between the increasing atrial fibrillation yield, so you get more yield here, okay, and the risk of screening intensity increases, because to get more yield, you need to get more sophisticated devices. You want to get less yield, here, something like single ECG, which is easy, you can do for everyone, but the yield will not be as high as. So this is always trade-off between these two things. So this is again another way to look at it. So how intensity, yield, and the stroke Depends what device you single time point or continuous. This is you get more yield, but you cannot approach everyone. This one you can approach everyone, but of course you don't get much yield. So this is, then sometimes you do a combination. Depends where you are, which you know, if a place like Emirates or the Gulf, where the prevalence of atrial fibrillation we've seen based on Gulf safe is quite similar to the what happens in the West and in younger age even. So we can apply most of these devices together. Cost effectiveness, I think, is difficult to tell because these are actually based on model rather than real prospective study. And it showed you're able to save 6,583 euro, which is multiply 5, and about, because that amount, when you prevent a stroke, that amount you can save. Imagine how much we can save by doing that kind of screening. I think the big question remains this one. Those with clinical atrial fibrillation, we know when they have, you know, CHA2DS2-VASc less than 2, the risk of having, you know, thromboembolic is 2.8. What about those who are subclinical detected? It's very low, huh? It's getting higher as the CHA2DS2 goes. So not only we look at the you know, atrial fibrillation subclinical itself, we need to also look at the CHA2DS2-VASc. So, you know, AHRE does not equal clinical atrial fibrillation, which are really discussed. So this is very important. This is important, become important, but combination with the CHA2DS2-VASc. CHA2DS2-VASc higher, this has become important. You see here, you see that's patients at risk of 3.78 to have you know, thromboembolism when CHA2DS2-VASc is more than 2. So where do we stand? Detection rate previously unknown AF in the community 1 to 2. Again, and our part of the world is about 2.4. And post-stroke population with long monitoring time is detected 30%. In high risk asymptomatic population, we need to target above 75. I don't know, in our region, maybe less than that, 65, maybe even 55. This is kind of question remain, we don't know. Loop monitor for 3 years. You detect about big number, but again, it's very intensive. Twice daily 30, it's much easier, but it yield less. Cost of intervention, you need to think about cost of stroke as well, which is very high. Balance these two together. These questions remain, of course, will remain until we have, you know, further studies. So duration and frequency of screening, how to do, I showed you. And we can do it in an easy way. We can do it in a high intensive way. Depends on the prevalence of the atrial fibrillation in our region to know which one which tool to use or combination together. And then of course these are I think the studies were going to help us because they are ongoing, tell us about effectiveness, efficacy, acceptability, cost effectiveness, definition of screening population, and setting implementation across health system. And I think we hope this study going to help us to answer that kind of question. And these are the two studies ongoing, looking at those high-risk patients with high CHA2DS2-VASc to see where the subclinical atrial fibrillation, you know, intervening. Here is randomized clinical trial using aspirin. One of them is Rivaroxaban, the other one is Overdosing, to see if the outcome. Okay, we detected now subclinical atrial fibrillation. So what? Do they get the benefit? These are the two studies going to tell us the future. So, in conclusion, and I think I'm on time, atrial fibrillation screening meets many criteria for successful screening program, high degree of acceptability to patients for screening tests. Atrial fibrillation is important stroke risk factor, and there is established highly effective treatment. I think Dr. Mu'taz is going to discuss that with us. I showed you many studies, how they use the tools and different setting, different tool to detect and screen for atrial fibrillation. At present, the evidence does not show that screen-detected AF patients have the same cardiovascular risk or benefit from NOACs similar to the clinical. We don't know. You know, we don't know. We hopefully with these two studies will help us with this. Innovation in technology, I think that we need. We need something really smart and available for everyone, so we can tackle this together and able to detect it as early as possible, and then hopefully with the coming 2 studies able to have a better idea of management. Thank you very much.
Thank you, Abdullah. This is an excellent talk. It seems there are not too many questions, almost there are no questions in our session, so we'll keep all the questions maybe at the end of the second session. The second speaker is Dr. Mu'taz Qadri, and he will be talking about how is real-world evidence helping to inform care for the patient with atrial fibrillation.
Just give me a second. Let me just find where's the talk. Just 1 second. Can you see my screen?
Now, yes.
Okay. Well, good evening, everybody, and thank you very much for giving us, a couple of hours of your evening time on this holiday day. What I'm going to talk to you today is about the evidence from real-world data and how it's helping us to sort of understand how atrial fibrillation management is going to, to be in the future, or what we can do to improve it in the future. The problem with real-world data currently is that there's just a lot of it, and you can be sometimes very overwhelmed by the amount of data which is available. So the way I've structured the talk is slightly different. So I'm just going to talk a little bit about the difference between real-world data and randomized controlled trials. I'll go through the main findings of the big randomized controlled trial that really set the scene for NOACs to be used in clinical practice. Then I'm going to talk about the trends that are emerging from real-world data. And then I'm going to talk about the prospective real-world data registries, which I think gives better quality data compared to the retrospective studies. And then finally, I will show some of the really big real-world registries, because I think, with the huge numbers that are available in them, that will compensate for the deficiencies that we have with real-world data studies. Okay, so the strength of real-world data. So it's relatively low cost, it's effective, it happens in real practice. It's normally a large number of people, and the important thing is that it's a diverse population, as opposed to the randomized controlled trials, which tend to have really very specific population of people. And we also look at all sets of outcomes, not just necessarily the ones which were predefined in the randomized controlled trials. The limitations with real-world data is that, it's normally the kind of thing that will give you food for thought, really. So you can't often draw concrete conclusions out of it, but it would help you to sort of think about more research ideas for the future and how to design other studies to look into it in more detail. The problem with it is not randomized, and therefore it's subject to potential of bias. Frequently, particularly with the retrospective ones, you're really dependent on the coding quality. And if you have coding quality errors or missing data, then that will compromise your data. And a lot of confounding factors could be there. So to recap, the pros of real-world data, it gives you insight into the temporal trends. Okay, so it helps you to see how things are progressing in terms of time. It can also help you to confirm the results of randomized controlled trials in unselected populations. Okay, the randomized controlled trials tend to happen in a very specific group of patients that have very specific inclusion and exclusion criteria, whereas the real-world data does not have that. You're using it in everybody. It also can help you to look into the information on the pattern of using these medications. For example, things like underdosing or overdosing. The data reported often involves large number of patients, and that will tend to compensate for some of the disadvantages that you get with real-world data, and often can identify certain concerns with drug use. We've had many medications in the past that the randomized controlled trials were looking amazing, and then once they are in clinical practice, they end up being withdrawn because real-world data showed concerns that were not apparent with the randomized controlled trials. What's the downside with real-world data? The trial is not controlled, so you can't pick and choose which patients you're taking. You're really more or less taking most of the people that comes to you. And although it's also a positive, it's also a negative, having a heterogeneous patient group. So you've got mixed bag, you've got young and old, you've got all sorts of comorbidities with them. And that's good in a sense, because you're getting to test the medication on this group of patients, but equally it will tend to dilute the effect sometimes. You've got uncontrolled influence of non-compliance. So normally with randomized controlled trials, the patient tend to follow advice, and normally the level of compliance is very good because they're followed up by research coordinators and so on. In real world data, there's nobody chasing up these patients, so they might just stop taking the medications. And the big problem with real world data is you have missing data. So what was, if the patients were all taking non-steroidals and they're on a NOAC, they might end up with bleeding, which might show that one of the NOACs is worse than warfarin, for example. Other comorbidities which are around, if you don't have it, you may not be able to compensate for it. The time and therapeutic range, the EGFR, all of these things can affect the outcomes unless you can correct for it. So when you're looking at real world data, what should you be looking at? Okay, so the size of the population, and I think this is one of the biggest things. So the bigger your population, the stronger the level of evidence that comes out of it, and the more accurate or the more closer to reality the information or the data you get out of it. So if you get real world data with like a couple of hundred patients, it's very different to a real world data which has 500,000 people in it. Are there different prescribing patterns depending on the country? For example, the Bigatran 110 is not available in the US. They have only the 150 and 75. So if you get any real world data from the US, you're not going to be able to assess the 110 milligram dose there and so on. What type of analysis is being done? Is it claims-based, or is it insurance database? And these have huge disadvantages because they're heavily dependent on the coding. And sometimes if you have hospitals which are over-coding for certain things, you will end up picking up lots of things which are not there in reality. Is it country-based? Is it nationwide? Is it international? That makes a big difference. And is it prospective or retrospective? So the prospective ones tend to sort of have well-defined criteria in terms of what kind of data you're collecting. So the quality of data that you're collecting is significantly better than the ones which are retrospective, because retrospective ones, you really can't determine what's being collected because it's already been collected from before. Has there been propensity matching scoring to accommodate for any differences between the groups in other variables? And is there any variation in the follow-up period? So you might get a database that follows up the patient for 1 year and you get, let's say, a stroke rate of 1%. And then the other one follows up the patient for 3 years and they have a more stroke rate in 3 years of 3%. Now you might say, well, 3% is more than 1%, but that's really 1% per year. And that's more or less in a way is comparable. So what does the randomized control trial say about the NOACs in atrial fibrillation? So this is a very nice meta-analysis from 2014 from Dr. Ruff, and it looked into the 4 clinical trials that were performed with NOACs, and it looked into the risk of ischemic stroke or systemic embolization, and all of them really were better than warfarin to a varying degree. So, the Bigatran and Apixaban were significantly better than warfarin in terms of reducing the risk of ischemic stroke and systemic embolism. Rocket AF and Engage AF TIMU, so Edoxaban and Rivaroxaban had a strong trend towards better outcomes. But overall, there was almost a 20% reduction in the risk of ischemic stroke and systemic embolism. If we look at the risk of major bleeding, again, there's a trend towards lower bleeding. So about a 15% reduction in the risk of bleeding combined. And again, there's a difference between the NOACs there. So Apixaban and Edoxaban were significantly better than Rivaroxaban and the Bigatran in terms of the risk of bleeding. But anyway, neither of them was worse than warfarin. So you're at least as good as warfarin there. And if you wanted to look at the subgroup analysis of these studies. So if you look at the risk of ischemic strokes, for example, the NOACs really reduce the risk of ischemic stroke, MI, and all-cause mortality. But the bigger thing where it actually really shined is the reduction in the risk of hemorrhagic strokes and intracranial bleeds. There's about a 50% reduction in the risk of intracranial bleeds. That comes at a slightly higher risk of GI bleeds, and that also varies between various NOACs. So what do we know to summarize? 19% risk reduction in stroke and systemic embolism, 52% risk in hemorrhagic strokes, a bit of reduction in all-cause mortality, about 10%. Major bleeding, fairly similar to warfarin. There's a bit of an increase in GI bleed, and this is basically what we know from the big 4 randomized control trials, about 70-something thousand patients. Okay, so how about the real world data? So the first thing we're going to talk about is the trends that we're seeing from real world data. So we've had NOACs now for about 10 years. So one of the things that we can see, this is data a little bit old now, it's about 5 years from Jeff Barnes in the US. And what it shows is that the use of anticoagulation overall, which is this blue line on the top, is increasing, which is a good thing. So we're anticoagulating more patients. The green line, which is the warfarin, seems to be gradually going down. And the red line, which is all the NOACs, they seem to be going upwards. So the trend worldwide is that there's an increase in anticoagulation, reduction in the use of warfarin, and an increase in the use of novel anticoagulants. This is data from Garfield AF, which is an international database. And the beauty about this is that it shows you the cohorts per year. So 2010 to 2011, 11 to 13, 13 to 14, and 14 to 15. And the subgroups are very, it's very, very elegant, shows things. So the dark deep blue is basically patients who are not getting any anticoagulation whatsoever. And that group does not change in those 5-6 years, okay? So there's about 10% of the people, we all know them, okay? These are people that you think, I can't anticoagulate this person. Those are people who had multiple, let's say, bleeds. You can't put a left atrial appendage closure. These are people that you're not going to be able to anticoagulate. The lighter blue one, which is the aspirin, so that used to happen in about 30-something%, and that has gradually decreased with time, okay? And then the lower part, which is probably about 60-something%, that's anticoagulation. The dark red is warfarin. So as the time progresses, you can see that the dark red is becoming less and less. So we've got less warfarin usage. The orange one is the NOACs, and these are increasing. So from the beginning to the end, you will find what happened is that the amount of anticoagulation, which is from the yellow to the red, has gradually increased over those 6 years, from about 60% to about 72%. The amount of people who are using antiplatelets reduced, which is a good thing. The amount of people which are using warfarin has gone down, and the use of NOACs has increased. This is a Danish registry which is looking into the amount of discontinuation or non-persistence in terms of using the anticoagulation with patients with atrial fibrillation. And what you can find is that people who were taking warfarin had the worst discontinuation. So these were people were more frequently leaving anticoagulations, reaching up to 50 or even more %. And the best two were Rivaroxaban and Apixaban, which had almost sort of overlying lines, followed very quickly by the Bigatran. So it seems that the persistence in terms of treatment or adherence to the treatment and taking the medication seems to be better with NOACs than with warfarin. What real-world data, this is a new study that was published about 3 months ago that was looking into the pattern of prescription for these patients. Okay, so about 60%, so this is the total cohort, so about 60% of the patients were being prescribed the medication as it should be prescribed and the recommended dosages. But the worrying thing is that about 1/3 of the patients are still being undertreated. And this is a trend that has been seen in multiple other studies as well. Interestingly, there's about 8% which were still being overtreated. Amongst those, you can see that, for example, Apixaban had a very low percentage of the people being overtreated. But all of them really had that degree where patients were, all of them or the majority of them were undertreated. So the underdosing is a very frequent problem that we face in real life. And for you to reproduce the results that you have in major landmark clinical trials, you need to be using the medication as per the dosages which were used in that landmark trial. So when you give somebody 2.5 of Apixaban or 15 of Rivaroxaban, they don't qualify for that dose. You're only really increasing their risk of events. What's the problem with under or overdosing? So this is data from the European Orbit AF registry, and it shows that if you underdose, which is the yellow, or overdose, which is the red, you have worse outcomes. So you have more major bleeding, okay? You have more, the blue one is the underdosing, and the red one is the overdosing. Okay, and the yellow is the recommended dose. So you think you have more bleeding, more embolic events. Maybe you have less MIs with overdosing, but overall, your all hospitalizations increase with underdosing and overdosing, and your all-cause mortality also increases with underdosing and overdosing. So it's really very important to prescribe the medications as per their recommended dosages. Okay, so let's go to the real-world studies. And as I said, I will start with the prospective registry. So for example, this is Gloria AF, which is an international registry for the use of the Bigatran. We have now got data from phase 2, which has about almost 5,000 patients on the dabigatran, and we're awaiting the results from phase 3, which will have about 20,000 patients in it. And what you can see here is that they've compared the data compared to the landmark trial, which is RELY. And you can see quite nicely that the risk of stroke in RELY was higher than in real life. The risk of major bleeding in real life was lower. The risk of life-threatening bleeding was lower, and the risk of vascular death was lower. So this is actually very sobering and very nice to see that in real life, when we're using these NOACs, their risks are actually lower than what we have actually even seen in the clinical trials. So they've outperformed their landmark trials. If we look at the prospective registry from Rivaroxaban, Zamtis, and again, the data in Zamtis is in red and the data from ROCKET-AF, which is the landmark trial, is in blue. You can see that mortality was the same. The risk of stroke was higher in ROCKET-AF. It's lower in Zamtis in real life. The risk of major bleeding is lower as well. And you can see the difference in the CHA2DS2-VASc between the cases, between the two cohorts. So overall, again in Zamtis, Rivaroxaban seems to appear to be as good as Rivaroxaban in the landmark trial, if not better from it. Here's data from Aetna, which is Aetna-AF, which is the registry for edoxaban, which is becoming more available in the Middle East. And on the top panel, you can see the data from Aetna. So these are the risk of stroke and systemic embolism in these patients. And you can see this is for all the patients. This is for edoxaban, the green 60 milligrams, and the blue is edoxaban 30 milligrams. And below it is the data from Engaged AF, which is the landmark trial. And again, you can see that the data in the registry is lower than the data that you have in the study. And the same trend is also in terms of hemorrhagic strokes as well. So it seems to be lower in real life as well. This is data from a Danish registry presented by Larsen in 2016. So this compared all the NOACs available at the time with Warfarin. You can see the data shows that the dabigatran and apixaban had lower risk of major bleeding. So this is predominantly a safety registry. It was not looking into the risk of stroke here. So you find that apixaban and the dabigatran had lower risk of bleeding compared to Rivaroxaban and Warfarin. And equally, the all-cause mortality had showed a similar trend there as well. Then I'm going to move to something really large. So Aristophanes is a very large real-world study. So it was published about a year ago. It had, almost 500,000 patients in it, 450 something. So a huge number of patients were in that trial. So what did it look? So it's the largest known observational study of NOACs to date. So what they did is they compared apixaban to the other medications and they compared it to warfarin. So here in the comparison to warfarin, we can see that the risk of stroke and systemic embolism is lower than warfarin, and the risk of major bleeding is significantly lower than warfarin. Okay, so this again confirms the data that we have from Aristotle. And if we look at the risk of bleeding, the risk of GI bleeding is significantly lower in this study compared to warfarin. How about if we compare the dabigatran to warfarin? Well, the risk of stroke and systemic embolism is showing a trend towards reduction in the risk of embolism, but the risk of major bleeding is significantly lower. So that's very good. However, the risk of GI bleed appears to be similar in this cohort compared to warfarin. And if we look at Rivaroxaban, the risk of stroke and systemic embolism, again, there's a trend towards being better than warfarin. The risk of major bleeding appears to be similar to warfarin there. So what you can say here is that compared to warfarin, all of these NOACs were at least as good, if not better than warfarin, with apixaban probably having a bit of an edge there. And again, the risk of GI bleeding compared to warfarin with the Rivaroxaban was a bit higher. How about if we compare NOACs to NOACs? And it's difficult. I really hate it when we have to compare NOACs to NOACs because this is not a head-to-head study, and therefore you can't really compare them. They're not apples to apples. So unless you have a head-to-head study comparing these two medications, these are only really just an indication. So we can't really use the data out of this as concrete evidence. So apixaban compared to dabigatran, lower risk of embolic events with apixaban, lower risk of, or a trend towards lower risk of bleeding with apixaban as well. If you compare apixaban to rivaroxaban, you will find that the risk of stroke again is lower with apixaban, and the risk of bleeding is lower with apixaban. And if you compare the dabigatran to rivaroxaban, you will find that the risk of embolism is more or less the same between them, with a bit of a lower risk of bleeding with dabigatran. And finally, I'm going to talk about the Maxis study, which is again about 350,000 patients. The huge benefit with this is that it included almost 90% of the French population who had AF. And that recruited patients for about 4 years period and followed them for several years as well. And it reported in 2020. It's a very recent study. So what we have here is comparing apixaban to warfarin. And you can see a significant reduction in the first graph with in terms of the cumulative risk of safety events, so major bleeding leading to hospitalization. So bleeding risk was much lower. The second panel is basically the risk of stroke, which seems to be lower again with apixaban. And the third one is the all-cause mortality, which is again significantly lower with apixaban compared to warfarin. And this is basically the data that we saw in Aristotle as well. If we look into apixaban versus rivaroxaban cohort, so you will find that the risk of hospitalization or the risk of bleeding is lower with apixaban. The risk of stroke seems to be the same, and the all-cause mortality seems to be the same between apixaban and rivaroxaban. And if you compare apixaban to dabigatran, you will find that the three graphs are more or less the same. So you'll find that there is a bit of a difference between this big real-world data, and that's because they're not really well matched in terms of the populations. So it doesn't really replace a randomized controlled trial, but it really gives you a trend that overall these medications are significantly better than warfarin. Amongst them, there might be tiny differences, but overall they're all much better than what we had in the past. So in conclusion, what we can find is NOAC use has been increasing steadily over the years. Misdosing, unfortunately, is still a major problem. At least about 40% of the patients are still not on the correct dose of the NOAC or anticoagulation. And NOACs are safe and effective alternative to warfarin. In all the real-world data that we have seen, these medications have been either equal or in most instances even outperformed warfarin in their safety and in their efficacy as well. The data is very consistent with the results from the pivotal clinical trials. And again, on multiple occasions, we see that the data from real-world data is even better than what we have seen in the pivotal clinical trials. There's a significant reduction in intracranial hemorrhages and major bleeding. This is, I think, one of the bigger effects of NOACs, and a smaller or lower risk of ischemic strokes as well. And with that, I would finish my talk, and I'd like to thank you very much. And if you have any questions, I would be more than happy to take them.
Thank you, Marquez, for this excellent talk. I think we'll open now for the question. Let me start with the one question here from one of our audience. And here's the question for Dr. Abdullah. And you mentioned the screening at the age of 65 and above is more yield to pick up Afib and more. And the question here is the patient with high risk, heart failure, hypertension, ischemic heart diabetes, or in other words, the patient with high fast SHAD is maybe the best to be screened, not by age.
Yeah, that's what we said, Dr. Salim. This is what the guidelines say as well. It's not the age. Age is an important part of CHA2DS2-VASc. But if you look at the things he mentioned, hypertension, heart failure, ischemic heart disease, all these are parts of CHA2DS2-VASc. The more higher CHA2DS2-VASc, the more the yields, either for clinical atrial fibrillation or for subclinical atrial fibrillation, definitely.
Okay, so we could summarize on the patient who have high CHA2DS2-VASc, for example, patient who's diabetic, hypertensive, ischemic heart disease, even if they are at the age of 50, maybe it's worth to screen this patient for Afib. But if the patient is very low risk, is not hypertensive, not diabetic, and he's a 65 and above, maybe also it's worth to screen these patients trying to pick Afib, which may cause a stroke. Is that fair, summary?
Excellent.
Okay. So there are another question open for both. How can we relate that the stroke is coming from Afib, not from atherosclerosis? There was a question here saying, how can we be sure that the stroke is Afib related Okay, so in cryptogenic stroke, how can we make sure that is AFib related and not thromboembolic?
So I may best start by answering. So, I mean, normally speaking, when you have somebody who gets a stroke, they will end up undergoing a battery of investigations. So a lot of the times, the type of stroke that you get on the CT scan will guide you towards this being an embolic event or whether it's a local thrombosis within the vessels of the brain. The second thing is that if you have an embolic event, most of these people will have to undergo things such as, carotid scanning, echocardiogram. So, I mean, obviously, if you pick up something like, LV thrombus and somebody gets a stroke, then the most likely thing is that the stroke is from the LV thrombus. Or if you have somebody with significant stenosis in the carotids. The term cryptogenic stroke basically applies to people who have been investigated and all of their investigations were negative. In other words, there's no other obvious cause why they've had that embolic event. And with that, you will need to start thinking about subclinical atrial fibrillation, which could have potentially caused this. And then you need to decide on how long you are going to, follow up these patients and monitor them and see if you can pick up atrial fibrillation. So in the Crystal AF, I think they, putting implantable loop recorders, they managed to pick up roughly about, 30% at 3 years, about 30-something%, incidence of atrial fibrillation in these patients.
Yeah, I think that's well said, Dr. Salem. It's a third of the stroke, is due to the atrial fibrillation. So again, depends on your suspicious. I mean, if 10% of them, you see the atrial fibrillation in front of you. Those who are suspicious, as Dr. Maaz said, we need to do all that to yield.
I will reframe the question, but just to make sure this audience is from his question, he means different thing. Let us assume you have a patient who is 65, diabetic, hypertensive, okay, and also he had an AFib and have a stroke. Is this a stroke is AFib related, or is it maybe atherosclerosis? And that sometimes is not easy answer to which one, but the treatment is the same, isn't it?
It's always a difficult question to ask because you're trying to look retrospectively and see what caused that stroke. And if the atrial fibrillation episode is terminated, for example, if it was due to atrial fibrillation, you really have no way of telling whether this patient had atrial fibrillation before or not. So you're really dependent on having more atrial fibrillation in the future that you can pick up. As we've just said, like you pick up atrial fibrillation about 1/3 of the patients with implantable loop recorder. But there's been a study that specifically looked into these patients with cryptogenic strokes on starting them empirically on anticoagulation rather than antiplatelets, which is the standard treatment. And this did not show any evidence. And this is purely because, you're giving to 70% of the people anticoagulation, which is not needed. And only 30% are going to be benefit out of those people who've had a stroke. So therefore, you are going to be increasing your risk and you're offsetting any benefit that you're getting from anticoagulation and that 30% who's got atrial fibrillation by the increased risk of bleeding that you have from the 70% who don't have atrial fibrillation. So the recommendations would be, and they will probably continue to be so for the near future, is that you actually need to document atrial fibrillation before you can anticoagulate those patients.
Yeah, but Salim, you mentioned patient already got atrial fibrillation, so you have the evidence. That's clinical atrial fibrillation there.
You already have an evidence of AFib. If you have an evidence of AFib, the management will be the same, isn't it?
No, absolutely.
Yeah. So knowing it's atherosclerosis or it's or from AFib, you will end anticoagulating this patient to tackle.
Correct. Correct.
Okay. So. There's another question here. How frequent we need to monitor or check the INR for a patient with Afib and Warfarin?
I mean, it depends on how reliable or how stable the INR is. So initially, when you start Warfarin, you will have to monitor it more frequently. The UK guidelines was that if it is very stable, you can do it once a month. And occasionally people were doing it even once every 6 weeks. With the advent of home monitoring for INR, so you can give sometimes patients the home monitoring kits, they can do their own INRs and they can phone anticoagulation clinic with the INR reading and they could be told how much you need to modify their dosage. But a lot of the times, if you have a clinical suspicion that something may have caused the INR to change. So for example, if somebody took antibiotics or was started on amiodarone or, had lots of spinach or something like that, then you might have to just to check your warfarin or INR levels. If somebody has got very labile INR, it goes up and down, then again, you need to check it more frequently and possibly offer them home monitoring for it. But if the INR has been extremely stable, then you can probably do it once every 4 to 6 weeks. However, the latest ESC guidelines that came out a couple of months ago, they were more in favor of swapping, from warfarin to a NOAC if the patient has labile INR and they're not achieving time in therapeutic range of more than 70%. And this recommendation is now stronger than the recommendation of trying to optimize their INR, if you know what I mean. So if you have somebody where the INR is all over the place, then the ESC guidelines would recommend changing to a NOAC at this stage.
Actually, Dr. Mu'adh, there's been a challenge, Dr. Salim, during the pandemic. We had a really problem of getting patients INR checked. So we slightly increased that timing from 1 month to 6 weeks to 2 months sometimes, based on what Dr. Mu'adh said. And again, really, it's NOACs. It should be an answer for future of these patients.
Yeah, but if you are checking, if you have no option other than warfarin, let me summarize, and you can comment if you disagree. If the patient is just naive to warfarin, you may need a baseline INR just to make, and PTT to make sure that his INR is normal. And then you start warfarin. Maybe you will repeat one and the third day to decide if the dose is enough. And then you will keep repeating it until it's therapeutic in daily basis, in therapeutic range. And then you may continue doing it once a week, okay, to make sure that's stable. And when the patient is stable in regular dose, then you will do it maybe once a month, okay, one every 4 weeks. And as I agree with Dr. Mu'taz, if the patient take antibiotic, changing his habit of diet, maybe he need to do it frequently, less frequent or during that change. Is that fair protocol generally?
Yeah, agree.
Okay, so there are another question for you guys. Would you recommend aspirin as thromboprophylactic among those who are not considered to be high risk?
Aspirin out.
Yeah, I agree as well. Aspirin has no role in prophylaxis, and to be honest, I think Dr. Abdullah could even answer that. I mean, even in coronary artery disease, it probably is out for prophylaxis, just based on the high risk profile if they haven't had coronary artery disease. But for AF, it has no role.
Okay, so if then the question is the answer is no. Even if
the answer is no.
The answer is no if they have no AFib. It's just as a prophylactic, and the answer, even if you have an AFib, like with the chat fast 0, okay, or maybe 1, aspirin is not maybe the option and not recommended. Do you agree, guys?
I think they might be implying to the American guidelines, to the AHA guidelines, which were a couple of years back, and they kept the aspirin in those relatively low risk group. But I think the latest update that they had in 2019 even changed that. So currently aspirin is, I don't think it's even in the American guidelines as well. It's out. It's out for the better, I think. I think the European guidelines were very progressive about this, and the American guidelines were just lagging behind. But I think in the latest update that they had about a year ago, or less than a year ago, I think it's out as well.
Okay, so the aspirin is out in treatment of the AFib. Okay. Okay. Let's see. Is it, so I think this question is for you, Mu'taz. Is there a difference in real world data as more safe is related to using the lower dose more?
There's not actually a lot. If you remember, I'm still sharing my screen actually. I can show you the slide that I showed before, which is, in terms of, the risks, it's actually not safer. It's actually, the underdosing is actually, so if you look at this one, if you look at the underdosing, so the risk of bleeding is no different than being on a normal dose, and the risk of embolic events is higher. The risk of MI is not better. The risk of all hospitalization is not better than being on a standard dose. So I don't see why using lower dose or somebody who does not qualify for a lower dose would be better. There's another big European registry which was specifically looking into that, and the people who are on the lower dose have even more bleeds than normal people. And I'm assuming it's because some of these people were started on the lower dose because they were considered to be at higher risk of bleeding, but it did not show a lower risk of bleeding compared to the standard dosages. So as I said, there might be bias in these real world data. But overall, the data so far does not show that the lower dose is safer. So you definitely have a higher risk of stroke and ischemic events, but you're not making your patient any safer, I think.
Okay. I have a question for you, myself. Regarding, I can understand if the physician in real data, they go for underdosing because they are worried about the side effects, maybe GI bleed and these things. But I can't understand why they will go overdosing and what's the reason overdosing. And sometimes it's reached to 11%.
I know. And I don't understand the reason behind that. I mean, sometimes it could be prescribing error, sometimes it might be patient error, but I honestly don't understand why people would overdose on anticoagulation, because we really don't have any evidence that the higher dosages are any better, to be honest.
Okay. Let me ask you, there are a question from one of our audience. Are you using the Apixaban if the GFR is below 20?
I would still probably use it. I become very cautious when I'm using it. The problem in these people with very low GFR is that warfarin is just not a better option for them. I mean, warfarin is associated with higher risk of bleeding, particularly with things like Apixaban. It's actually worse than Apixaban with putting them on warfarin. So the risk of stroke is higher and the risk of bleeding is higher if you put them on warfarin. So you're trying to find what the lesser of two evils in these patients. You would have to look whether they would qualify for the reduced dose, and if they do, you need to reduce it. If the patient is on dialysis, then currently there's FDA approval for it to be used at the higher dose actually during dialysis. And that's what our nephrologists are doing in our hospital. So they are swapping a lot of the patients from warfarin to Apixaban because it makes life easier in terms of managing their anticoagulation and their INR. But it's a difficult question. You're doomed whether you use warfarin, you're doomed whether you use a NOAC. If I had to use a NOAC, I would probably use Apixaban because it's the one which is least excreted through the kidney. But, and I would look very carefully to see if there's any chance that the patient would qualify for the lower dose. And if they do, then I would reduce the dose.
Okay. What about Dr. Mu'taz? Is any change in the issues of Afib regarding the rate control or rhythm control? Is any benefit?
So if you look at the data from 20 years ago from the Affirm trial, the headline figure from the study was that rate control versus rhythm control, there's no difference. If you look into the subgroup analysis of that study, the people who actually were in sinus rhythm did better than the ones who were in atrial fibrillation. The problem with the Affirm is that it was based on using medications which were very dirty, like amiodarone, like flecainide, which in itself caused a lot of problems. There's a lot of real-world data to suggest that ablation is a better option. So we know what we know from the Framingham sort of data set that if you are in sinus rhythm, you do better than somebody who's in atrial fibrillation. We know from the Affirm trial that if we bring you back to sinus rhythm with medications, we actually have no benefit. Okay, you're still as bad as somebody in atrial fibrillation. So maybe the answer would be to try and maintain sinus rhythm in another way apart from medication. And this is where ablation would come into the picture. We've had recently the Cabana study, which was published about 18 months ago. And the Cabana study, again, the headline figure from it was that ablation was no better than medication or rhythm control or rate control in patients with atrial fibrillation. But again, Cabana, you need to look slightly into the subgroup analysis of it because the people who actually had ablation, it was an intention to treat study. So some people did not end up they were within the ablation group, but didn't end up getting ablation, but they were analyzed as being somebody within the ablation group. So these people, it's unfair to ablation to say, well, I'm going to analyze this person as if he had ablation, but this guy never had ablation because he withdrew his consent or he ended up moving to medications. But if you analyze the ones who actually had ablation, these people did better than the ones who were on medications. And finally, within Cabana, there's a couple of subgroups that were very interesting. So one of them was the people with reduced ejection fraction. These people did much better than the people with normal ejection fraction. And the people who were younger in age, so less than 65 years of age, these people did better than the people who were older, which makes sense. So the findings in terms of the heart failure were also confirmed with Castle AF study. So patients who had AF ablation with impaired LV function, they did better than the people who did not have ablation. So currently the guidelines are still saying that if AF ablation is predominantly for symptom control, the only group that I'm very aggressive about offering them ablation at an early stage would be the ones who have impaired LV function, particularly if I can confirm that their ejection fraction gets better if they're in sinus rhythm. So that's a group that I very actively sort of pursue a rhythm control strategy there.
Dr. Salim, Dr. Mu'taz, since you are electrophysiologist, depends on what you want from rhythm control. Are we looking at mortality or are we looking at quality of life? I mean, when I get my knee replaced, I need to improve my quality of life. So if I'm able to improve my quality of life by rhythm control, to go with it. Why I'm looking always at mortality improvement?
No, I agree with you. And this is the reason why the recommendation from the guidelines is saying symptom control, because that's what we have evidence for in real life. However, with Castle AF, we had even strong mortality and heart failure admission improvements. And that's why it's gone up in the guidelines now, AF ablation for heart failure. So predominantly, if I get somebody who's completely asymptomatic, it's very difficult to offer them an AF ablation because I can't make him better than what he is. Having said that, some of those people have subclinical kind of shortness of breath and tiredness. And if you cardiovert and they tell you, oh, suddenly I feel significantly better, I've got more energy. So then that counts as symptomatic atrial fibrillation. I would want to keep them in sinus rhythm. But if I have somebody who is truly asymptomatic, it's a very difficult decision to offer them ablation unless the patient specifically pushes for it. But I don't have any evidence to say, well, I can't make him live longer and I can't make him feel better if he's already feeling great. But for the ones with heart failure, we do have now evidence that we actually prolong their life and we reduce their hospital admissions with heart failure as well.
Plus, we treat paroxysmal AFib slightly different than permanent AFib. We know the patient with the paroxysmal AFib, we don't go for rate control. We try to keep them in sinus, and because we know the tool which atrial fibrillation, ablation is very good tool in this patient to keep them in sinus, and you are more successful with it. Okay, but these type of patients we will try to go with the rhythm control in the paroxysmal AFib, especially in young people. The permanent AFib, it's as what Dr. Mu'taz mentioned regarding their management. If they are symptomatic, is indicated. If with heart failure, there is indicated to go with the more good control, especially with the ablation, because the antiarrhythmic it's have side effect and risk of arrhythmia by itself.
And it's important to understand. I mean, success is a very variable term, okay? So in Castle AF, which found the data about heart failure admissions and mortality, in the vast majority of them, they did not actually cure the atrial fibrillation. They just significantly reduced the AF burden. That in itself was associated with an improvement in mortality and heart failure admissions. So sometimes we're a little bit too harsh on ourselves in what we judge as success. So if you want to be a purist, you're going to say, I don't want anything more than 30 seconds of AF in the first 12 months after an AF ablation. But that's a very hard endpoint if you have somebody who's got an ejection fraction of 20%, have got a dilated left atrium. And what might be that if you reduce his AF from having an episode of AF that would last 3 days every couple of weeks to having like 2 minutes of AF every 1 month, that in itself is success, and that would improve their outcomes as well.
Okay, back to the NOACs. So there are a question, which NOACs is better in a renal impairment and diabetic patient?
So, I mean, I said renal impairment, the way I would rate the NOACs is my least favorite would be the dabigatran, followed by Rivaroxaban, followed by edoxaban, followed by apixaban. And that's purely based on how they are cleared by the kidneys. And in a sense, that would also affect how they would, they're affected by how poor the renal function is. And particularly apixaban and edoxaban are probably the safest in terms of bleeding. So when you're giving these medications for somebody with renal impairment, what you're worried is that they're going to retain the medication and they will be over anticoagulated and they'll end up bleeding. So the two safest in terms of bleeding is currently in most of the real world data and even the landmark trials are edoxaban and apixaban. So these would be my two favorite ones. Edoxaban I don't think is licensed below the GFR of 30. So below GFR of 30, it will probably be predominantly apixaban. And in diabetic patients, I don't necessarily have a preference for it, although there's some subgroup analysis from real world data saying that Rivaroxaban tends to be better than the others in the diabetic patients. But again, that's subgroup analysis of a real world data study. So the data is relatively weak for that. But, if I have nothing else to compare to or no other strong reason to prescribe another NOAC, then maybe Rivaroxaban might be the right thing for a diabetic patient. There's some data to show that it actually slows the progression of their, renal impairment in diabetes. So, but again, that's a subgroup analysis of a real world data.
Yeah, but in summary, renal impairment, maybe you will put apixaban as the first choice and then maybe edoxaban.
Correct.
For diabetic, maybe the all is equal. Maybe there are some small evidence regarding Rivaroxaban. Okay.
Correct.
Okay. I think we went through that. Is again what the cut of value to use NOACs and renal impairment.
We said that.
We said mention it already.
Yeah.
Okay. An Afib and transplant. Okay, if the patient came to the emergency room and found to have an Afib, fast Afib, found to be hypotensive, dizzy, unstable, should we cardiovert? Or we should at least consult cardiology?
I mean, this should be ER, be great in acute management of atrial fibrillation, especially this patient is unstable, as you said, hypotensive, already got all the symptoms, so cardiovert, yes, definitely. DC cardioversion.
So if the patient unstable, if the patient is stable, I think you need to put him back in his rhythm. Yes. If the instability is because of the fast Afib. Okay.
Yeah, I mean, sometimes, you have to look at each patient individually. I mean, a bit of dizziness and a BP of 95 is not really that unstable. And you can say, okay, well, I'll rate control him and see what we need to do and see if I need to TE him. If the blood pressure is like 60 with dizziness and hypertension, well, that's different. You have to cardiovert them straight away.
Okay. I agree. And sometimes you may give them the fluid and the blood pressure will go up, you know. Depend on which type of patient.
Sometimes you give them some digoxin, slow down the heart rate, the blood pressure would pick up. I mean, it's difficult to give concrete answers for questions like that because it really depends on, I might see the same patient with the same story, but I treat them differently depending on how bad their blood pressure is.
Exactly. And for example, if you have a patient who's young and with a very fast Afib, usually if you give them fluid and maybe rate control them with the beta blocker, even if they are, or control with the digoxin, even if their blood pressure is low, you will be able to manage them.
Yeah.
Without quickly cardioverting them. Okay.
Salim and Mu'taz, if you look at the registries of atrial fibrillation, it varies the practice. In European, DC cardioversion is predominant in 90% even regardless. And our Gulf SAFE, was very low DC cardioversion, again, regardless of, the presentation. So it depends where you are, practicing.
I would agree with you. There's two aspects to this. So one of them is that the clinical history tends to be way more reliable in the West than here. So what time did your palpitation start? The patient often can tell you exactly what time it started. So you can accept what they're saying. I mean, here you get really, really very vague stories. And the second thing, patients anticoagulated, for example, you ask them, are you taking your NOAC? Yeah, I've been taking my NOAC. As you're just about to press the button, you know what? I might have missed the last week and not taken anything. So again, they change the story very frequently. And finally, And I didn't really believe that until I came here, but I think the thrombophilic profile of the patients might be slightly different here compared to the West. I mean, I think we're seeing, and you probably see the same thing with coronary heart disease. I mean, like you worked in the West, you see people in their 30s, you would never cath them. Whereas here you see people in 30s and they've got horrendous triple vessel disease. And in a certain extent, I think we get something similar with AF. So sometimes you see patients, you never think that they have thrombus in the left atrial appendage. And when you TE them, you would find something. So my threshold currently is to TE people is lower than what I had in the West. And it's just because sometimes you end up seeing major things, and because the history is not reliable as well.
I agree with you. I mean, from my experience, in UAE, at least I know 2 patients where they're young in their 20s, and we have because the duration was not clear, we did a transvasoval echo, and both they have thrombus. So I think the patient here maybe more hypercoagulability. Okay, so another question regarding aspirin. If we are using the aspirin and we use it for stroke prevention, okay, and why we cannot use it in a patient to protect them from aspirin, from stroke, in a patient where Afib?
Because the mechanisms are very different.
The question by the audience is that the aspirin is effective in stroke prevention and thromboembolism and the atherosclerosis prevention. Why is not effective in Afib patients?
No, the mechanism is very different. So if you're looking at for example, when you get a plaque rupture in coronary artery disease, in a lot of the times you end up with a white plaque, and the white plaque is predominantly lots of platelets sticking to each other. And this is why antiplatelets work really, really well in these conditions like non-esterification MI, and even with strokes, which are due to rupture of atherosclerotic plaques. When you have a thrombus which is sitting in the left atrial appendage, a lot of this is really fibrin and a lot of and a lot of clotting factors together. And this clot is predominantly a red clot, and therefore antiplatelets have a very little role in that. They probably work a little bit, but not as good as anticoagulants. Whereas the opposite, if you're looking at atherosclerosis, for example, you can give warfarin, for example, for atherosclerosis, and it does reduce the risks a little bit, but not as good as aspirin, for example. So each one of them is a slightly different mechanism in my point of view. So for Afib, really, it's no match at all to anticoagulation.
Okay. So in the summary, is the mechanism of forming or causing a stroke is different. They are a plaque rupture in the atherosclerosis. Here is more of a stasis in the left appendage.
Right.
Which is
and Salim, it is a randomized clinical trial, not answering the mechanistic aspect. So we have clinical trials tells us the efficacy and safety, and did not prove it. So mechanistic, they are right. What they say is fine, but we cannot prove it in clinical.
Correct.
So if you have an old patient with subdural hematoma, okay, and he's in Afib, and he's taking Apixaban, okay, and also you have a recurrent bruising spontaneously in his skin, what will be your anticoagulation?
Apixaban.
Yeah, Apixaban.
Yeah. He's already, I mean, spontaneous bruises is not considered a major bleeding. So the subdural hematoma would be, but this, from what I understood from the stories, this is a history of subdural hematoma in the past, rather than a current subdural hematoma. So the current problem is only just bruises in the arms. That in itself is not normally an indication to stop anticoagulation. So an Apixaban is probably the lowest risk in terms of bleeding. So I would stick with the Apixaban personally.
Is there any alternative if again he developed subdural, while he's taking Apixaban again?
Left atrial appendage closure.
Okay. So in a patient who is failing anticoagulation or they cannot take it, the left atrial appendage closure device may be alternative approach to this patient. Okay.
So they need to have, they need to be anticoagulated or antiplatelet for a few weeks at least after the appendage closure. So you can't really have somebody who truly has a complete, absolute contraindication to anticoagulation. So they will need few weeks at least of at least 1 or 2 antiplatelets or anticoagulation so that you get the endothelium sort of covering the left atrial appendage closure device.
But the antiplatelets will be enough, isn't it? Not necessarily.
So it depends on the device and it depends on the series that you look at. So there are some of them who went from like 4 to 6 weeks and some of them necessitated 6 months. It depends, but I think you could probably get away with it with like 6 weeks of dual antiplatelet therapy. You probably will be okay in the majority of patients. And then dropping to a single antiplatelet.
Okay,
That's the problem, isn't it? You know, I mean, a problem with that. You know, they are very safe compared to warfarin, but still, you know, they still get intracerebral hemorrhage, but very low. But when you go for, you know, a device, as you said, appendage, you know, closure, again, you need to put them on some kind of antiplatelets or even anticoagulations. You know, it's not that easy when it comes to real life.
It's not, but a lot of these patients, like if you have somebody with a subdural, after a few weeks of the subdural, you can probably afford to give them a few weeks of anticoagulation. They'll probably be fine with that. And then you can say, okay, single antiplatelet. And then if they bleed with that, then say, actually, I've stopped it. I've given you the best chance. Rather than leaving you with appendage that could fill up with clots, at least I've blocked your appendage. This would be better for you. I mean, unfortunately, life is not straightforward, as you said, and we have sometimes to take difficult decisions with our patients. But you try to give them the best possible chance there.
so if you have a patient who is in NOACs and he got a hemorrhagic stroke, how we will handle the anticoagulation issues?
What the stroke, I mean, what the stroke colleague says, you need to stop, you know, that for at least 2 weeks, and then, you know, even further than that, and then come back. Then you go with, you know, what happens in the clinical trials is, you know, they had bleeding and they had to stop this and they had to restart them, and another maybe NOACs or the same NOACs or even back to warfarin. So I don't know. The answer is what exactly? What do you think, Dr. Mohammed?
It will depend on two. So the first thing is that if they are on a NOAC that has a reversal agent, then I would straight away reverse the effects of the NOAC to try and minimize the damage. The second thing that will make the biggest difference on when you can restart it again is really the first CT and then the CT scan that you do repeated after 3 or 7 days. And based on that, a lot of the neurologists would give you the advice on when you can restart it, because their major risk is really, is it going to extend or not? So if it is a massive, hemorrhage, then they will probably say, well, at least a month. If it is like only a tiny little bit of a bleed, then they would probably be okay after a week or 2. So we normally have to be guided by neurology and neurosurgery on this. But I would aim to reverse the anticoagulation if they've had an intracranial bleed as soon as possible, either with the reversal agent or with the plasma concentrate.
So in summary, in this point is it's a team decision or team plan between the neurologist, the cardiologist, and the neurosurgeon. Sometimes, if it's really a hemorrhagic bleed and it's big, and it depends. Is it a stroke that convert to hemorrhage, or is purely hemorrhagic stroke? What's the size? All this will play factors to decide what the duration you will hold the anticoagulation and when you can resume. Okay. So there are a question here, I will answer it for them. Is a patient with fast Afib in emergency department, can we start with anticoagulation immediately? I think you can start anticoagulation immediately unless you are planning to do any invasive procedure. If it's purely Afib, not for any invasive, ideally you should anticoagulate the patient immediately. And if you are planning to cardiovert him, you need to give him heparin or something during the cardioversion and you start anticoagulation. Okay. Can we apply charge-fast score for people with a sinus rhythm, especially if they are very high risk?
I think this is interesting questions. looked at the patient with heart failure and the patient with hypertension who are sinus, especially heart failure with reduced ejection fraction and hypertensive. And they, in the heart failure, they found is a kind of moderate, C statistics. Let's talk about the statistics. C statistics about 0.5 to 0.6, which is moderate. But in hypertensive, they found it actually similar to non-valvular atrial fibrillation. So usage of the CHA2DS2-VASc and hypertension, I think, and heart failure of use of at least moderate advantage.
But the question is, does it actually change? So if you have somebody who has a CHA2DS2-VASc, let's say somebody who is 70 years old, who's got diabetes and hypertension, so his CHA2DS2-VASc score is 3, but he's in sinus rhythm, you've never had any documentation of an arrhythmia, you still would not be able to anticoagulate him just based on that.
No, not for anticoagulations. Use it for prevention of the stroke and ischemia, and from more aggressive in terms of management overall. I don't think for anticoagulation itself.
Yeah.
So there are interesting question here. If you have a patient with hemophilia and he is in paroxysmal Afib, how you will deal with this patient from anticoagulation point of view?
I will put the hematology consult. These are scenarios which are not things that you face normally, and to be honest, they're out of the scope of all of the clinical trials. So you can't really have evidence, related to this.
And I tell you, I have one patient with this.
There is
So yes.
I just, that question is very interesting because we always look for something is rare. I mean, there are studies about the hemophilia. Again, those are with the really lower, milder kind of a stroke. If you look at the studies being published, it should be, individualize it. There's no big answer for, general answer for, it just depends on the patient in front of you. Then their CHA2DS2-VASc is almost, is lower than the other patient. But don't worry, these cases are very rare.
Yeah, it's very rare, but it's very, very, very difficult what to do with them, to be honest with you. And that patient, we anticoagulate him with apixaban, and he have no bleeding, to be honest with you. But we went with the smaller dose. But he was admitted just recently for another issues, surgical issues. And we found his INR is like in 5 and 6, to be honest with you. When he gets stress, his INRs go up, but we end up stopping it because we don't feel safe during this period to continue anticoagulation. But it's really difficult. We need to discuss, I think, with the hematologist. And okay, I think we answered this question. Okay, if you have a patient with liver disease, okay, and liver cirrhosis, but he's not in end stage yet. Still, can you use NOACs?
I'll put a gastroenterology consult. I mean, it's a bit difficult. I mean, the problem with these people, let's say if he's got cirrhosis, he might have, what you call them, higher risk of GI bleed because of, because of venous distension within the stomach. So, what is his risk? I mean, if this guy gets a bleed, and you remember, guys who've worked in the West, you see those people with cirrhosis who come in with GI bleed. They come in with GI bleed and they die within 1 hour. If you have somebody like that and you put him on a NOAC, you have to know what you're going to be doing. If I'm going to put him on something, I will be putting him on something that has a reversal agent. At least I can do something to stop the effect of NOAC on these patients. This would be my view about this. But again, it's a team thing. I will have to speak with GIs to can see if they've done banding for the varices, for example. They might tell you, well, his risk of bleeding is very low. You can go ahead and do it.
Okay, let us agree on this one. And if they have no esophageal varices or the risk of GI bleed is not high, I think you can use NOACs. but
I think
maybe
so.
the one which is not metabolized through the liver, and maybe if the renal function is normal, then choose the maybe dabigatran, because the dabigatran is having antidote and it's renal secreted. So I think, yes, you can use. If the patient have already advanced liver failure and you have esophageal varices, I think it's a team decision with the gastroenterologist to assess his risk of anticoagulation, okay, and the choice, because you need at least here also antidote, and maybe warfarin should be sometimes the only option in this situation. Okay. There are some comments that my voice and Dr. Abdullah Shahab voice is not clear.
That was a long time ago.
Mu'taz, your voice is good. Okay. It's loud enough.
You ran out of battery, Dr. Salim, I think.
Okay. I think it's almost, okay. It will be the last question if there are any questions. I think we answered this question. We said for aspirin, they have no role in Afib. In case of GI bleed, any alternative? Okay, let us just screen before finish. I think we answered most of the question. I think, thank you, everyone. Thank you, Dr. Mu'taz. Thank you, Dr. Shahab. Thank you for the organizing team. For this, thank you for the audience spending with us almost like 1.5 hours in holiday days, especially this religious holiday days for Prophet Muhammad Sallallahu Alaihi Wasallam. Good night, and thank you, everyone, for.
Thank you very much. Thank you very much. Take care.
Thank you very much, everybody. And sorry if there are a few questions that we didn't answer. It's just, it's been more than half an hour of questions, but they're all very interesting questions, and just apologies if we couldn't cover all of them. Thank you very much. Have a nice evening.